Good evening, everyone. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my privilege to welcome you all to today's important discussion titled Caring for the Whole Patient Support and Life After Leukemia. Before we dive in, let's take a quick note of the current landscape of leukemia. Leukemia, a cancer of blood and bone marrow, remains one of the most challenging cancers to treat. Yet, it is also one of the most rapidly evolving fields in modern medicine. India sees approximately 35,000 to 40,000 new cases every year. And while treatment outcomes have improved tremendously, challenges remain in early diagnosis, access to advanced care, and post treatment survivorship. Today, thanks to the scientific innovation, we have life changing tools, stem cell transplants, targeted therapies, and even CAR-T cell therapy that are redefining hope. But at the heart of leukemia care lies something deeper, the need to care for the whole patient, addressing their physical, emotional, and social well being. This evening, we bring together a truly distinguished panel representation: clinical excellence, innovation, policy, and patient advocacy to explore how we can strengthen leukemia care across the continuum from the treatment to life after recovery. Let me take a moment to introduce our speakers for the evening. Dr. R.M. Subai, consultant clinical hematologist, hemato-oncologist, and bone marrow transplant physician at Kauvery Hospital, Chennai. Welcome to the session, Doctor.
Hello, I'm from Kauvery Hospital, Trichy, not Chennai.
Oh, we'll get it updated. Dr. Karthik, Assistant Professor, Department of Hematology and Medicine, CSI Kalyani Hospital, Chennai.
Good evening to all. It's a very nice occasion to be discussing about leukemia, considering that this month is Blood Cancer Awareness Month. So I'm happy to be here.
Thank you so much for joining. Dr. Shouriyo Ghosh, Consultant Hematologist at Tata Medical Center, Kolkata. He'll be joining us shortly. Colonel Ajai Tomar, Chief Executive Officer, Indian Cancer Society. Welcome to the session, sir.
Thank you, Dr. Vaishnavi.
Thank you. So we have Dr. Shouriyo also. He has joined.
Hi, good
Welcome.
evening.
Dr. Vinita Srivastava, National Health Authority, Government of India. Welcome to the session, ma'am.
Thank you so much, and it's my pleasure.
So thank you to our dear panelists for joining our session. So let's begin our session. My first question is to you, Dr. Subai, that how do you decide between a stem cell transplant patient and other treatment options for leukemia patients?
Okay, so when we diagnose leukemia, there are some important things which needs to be done at the point of diagnosis itself. That is to see how what is the subtype of leukemia, how virulent it is. So we need to know more characteristic features of a particular leukemia to further continue treatment and then to try a cure to the best as possible. So some help would be from the clinical examination, as well as some would be from the laboratory tests, both basic as well as all the advanced ancillary techniques, whatever we have till date. So depending on the resources available and accessibility availability, the workup protocols may change from different institutes and even between different countries. So in general, after a basic history and a good clinical examination, when we evaluate, we have to see for how much the disease burden is causing trouble to the other organs, whether there's any skin infiltration or something what we call as extramedullary deposits, which is beyond the blood and bone marrow. It might involve some organs causing trouble. For example, the CNS involvement or the other organ involvements like skin and other visceral organs sometimes. Apart from this, when we do the basic blood tests and ancillary techniques to characterize the tumor, there is something called cytogenetics to see what are the chromosomal changes happening, which is sometimes which might be specific to a leukemia, and Also some molecular methods which helps us to find out what are the mutations which is causing that particular leukemia. And it's very heterogeneous, and every patient might have a unique set of aberrations like these. So we need to know what is the karyotype of that patient, or chromosomal abnormality, or what are all the mutations for that patient, so that we can categorize them. There are some classifications which would put them into a standard risk or a high risk, and individuals who come under this high risk would benefit from a transplant. So in a bone marrow transplant, what is being done is to destroy one's own marrow, and then we are going to replace it with a marrow from a suitable HLA matched donor. So those cells would resume hemopoiesis and would form the blood cells. So patients with a high risk category who harbor these abnormal, very high risk mutations or abnormal karyotypes, or those who have this extramedullary involvement, they would benefit more from bone marrow or transplant in comparison to the standard risk leukemias.
So yes, thank you so much, Dr. Subbaiah, for explaining it to us. So now, since we are trying to understand these treatment options, my next question is to you, Dr. Karthik. That how do you assess patients' readiness for and select the right donor for a transplant or CAR-T therapy?
Sure. So, first, like Dr. Subbaiah said, so we need to know whether they really need a transplant, which is based on where they stratify in the risk. So, whether they are low risk or high risk. Once we know that wherever they stand, the initial treatment is going to be the same, saying, see, we're going to try to bring the disease under control and to a best possible state, which is possibly we call it as an MRD negative or a CR. So the disease should not be in the body when we are going to attempt a consolidation with either a transplant or CAR-T cell. So we'll talk about transplant first, saying, see, how are we going to choose the donor and whether it's really needed, because we are presuming that it is a high-risk leukemia and the patient needs a transplant. So supposedly after the whatever initial chemotherapy was given, and if the patient is in a good MRD negative state, then I don't think there is anything else prohibiting a transplant, and the transplant workup is usually done simultaneously as soon as we know that the patient is high risk. And the donor selection, which takes priority, is basically something we called as HLA. So HLA typing is usually done with the siblings, which is one of the best of the donors because they share the same genotypes with the parents. Because they share with the patient. So we would do the HLA typing of the siblings if they are there, to see how much of a match they are. So HLA is not got nothing to do with the blood group, which is a common misconception, because I think we have a mixed crowd watching this video. So HLA is something to do with the genetics. So if they are a full match, then they would be a potential donor for that patient, and we would further work them up for the donor fitness. Stem cell donation does not require a bone marrow, which is a very common misconception, because the patients and the donor are scared that they will require a bone marrow for themselves, and it's usually like a blood donation procedure through an apheresis. So it's very easy to donate stem cells, similar to how you would donate blood for somebody. So if they are HLA matched, that is one of the primary criteria. In the HLA, there are specifications where we look at A, B, C, and further, if it's a high, elaborate typing, we would look at DQB1, DPB1. So these are all HLA intricacies which we would match to see if they are a full match. So if they are HLA matched, for example, they are a full match, the subsequent criteria would be something like age. So in the current era, if there is no match, that does not mean it's the end of the patient. So we do have other sources where we do resort to something called as matched unrelated donors, where we have registries and we can look up whether there is a similar match anywhere in this world where they can be able to potentially donate the stem cells. So if the matched unrelated donor or the related donor, which is the brothers and sisters, are available, then we would probably resort to other criteria other than HLA to choose, because we have multiple options. We need the best one to actually advocate transplant. So then we look at possibly the age of the donor, saying, see, the younger the donor, more better the stem cells are going to be. and the chances of us transmitting another unrelated mutation is less. So we would want a younger donor. The other things is usually for a male recipient, we would kind of prefer a male donor, because female donors who are postpartum, have children, might be exposed to the male chromosome Y and would have antibodies to it. So preferably a male donor and a younger donor, like we discussed. And other thing is CMV infections. Usually in the West, it is very common to find CMV negative. So CMV is one of the viral infections which is very commonly we are exposed to. So in India, I think everybody at a point of time would be exposed to CMV, and to find a seronegative patient would be very rare. And we usually see it in most of the mud transplants. So the best would be to have a CMV negative recipient and a CMV negative donor. So that's the best we can get. But since we are all exposed to it, that's kind of a theoretical criteria. So if the patient is seropositive, then we would also choose a seropositive donor. So that doesn't make sense. Even if there is a discordance, there are ways to tide over it. So that should not be a high criteria for choosing the donor. And currently we have advances where we use prophylaxis. So that is with tablets like letermovir. And with the current advances, I think the CMV kinds of blurs out as a criteria for selecting the donors. So after CMV, I would probably even keep ABO, like that's the blood group. Since I initially told you blood group doesn't matter. In choosing a donor, blood group does not make a big difference. But when we have multiple options, I would probably see which blood group is compatible, because not with the outcomes of transplant, but post-transplant, there might be problems like PRCA or the patient requiring multiple transfusions, which we can avoid if there are similar blood groups. So these are mostly the ones which we look up to, saying, see, how can we choose it? Current era, we have haploidentical transplants where even if you don't have a matched unrelated donor, or if you don't have a sibling, you can still go with half-matched transplants in the current era, because we have managed to deal with GVHD in a very good way with the current advances of post-transplant cyclophosphamide. That is one of the chemotherapies which are given after the transplant is done, with an ideology to prevent graft versus host disease. So that's a very good way to get a big array of donors, because once you go for half match, you can have multiple siblings tested, the parents can be donors. So we have lots of doors which open up if we have haploidentical transplant. Since the discussion is with leukemia, in haploidentical transplants, there is a better way to get that leukemia under control because of graft versus leukemia effect, because the mismatch is actually going to help the patient in getting rid of the disease. So that is a very good point, saying, see, when we have multiple options, we do keep this in mind, saying how much of a mismatch and how much of this mismatch is going to actually help the patient get rid of the cancer. So these are some ways where we look at how we are going to choose the donor for the transplant. But to answer the question of readiness for transplant, I would say, saying, where once his disease is well under control and he attains a CR or an MRD negative, has always been considered as a superior state to transplant somebody, because the post-transplant outcomes are very well if you have achieved that kind of a very low level of testing. So the MRD is by flow or PCR. With the advancements, we can even see to a minute level whether the patient has cancer or not. Coming to CAR-T, I think the CAR-T cell is one of the advances right now. With the evidence we have, we can't say that CAR-T cell is enough and we don't need to consolidate with transplant with the current era, but we are moving towards this as we have more evidence. So CAR-T cell is basically being used as a bridge to bring the patient to MRD negative state. So most people who are struggling to reach that state, we talk about the readiness for a transplant. If they are not able to do it, we do give CAR-T to kind of bring them into an MRD negative and consolidate with transplant. The CAR-T can also be used when the patient is transplant ineligible, in the sense it's a very elderly patient. He can't tolerate a transplant. So do we not give CAR-T? We do give CAR-T with a clause or an asterisk saying that, see, CAR-T might not be curative, but we do follow them up in a long run, saying, see, there is a chance of cure with just CAR-T alone. The problem comes with CAR-T persistence, because CAR-T is basically their own immune cells which are trained to kill the leukemia. So how long are they going to stay in the body is the question, because that's a very dynamic population of cells. So CAR-T persistence, if with time we do, with the subsequent generations, we are on around the second to third generations of CAR-T. So with time, if we are able to maintain that CAR-T persistence, then I do think CAR-T can be a definitive mode of therapy. But for the current data, I think we should consolidate with transplant. So transplant is a necessity post-CAR-T.
So thank you so much for explaining it in such an elaborate way. My next question is to you, Dr. Shouriyo, that how are new and emerging treatments like targeted therapies and precision medicine changing the way leukemia is managed today?
So thank you for the question. Uh, so leukemia is actually a very dreaded term. So when a patient or the family gets to hear that the patient has been diagnosed with a leukemia, be it a myeloid or a lymphoid leukemia, they are really setback. It's a big setback. They are, you know, it's a huge uh, hit for the entire family. Now, uh, prior to, I would say, prior to a decade, when there was basic, cytotoxic chemotherapies, the outcomes of leukemia and the ability to provide chemotherapy or the ability to give chemotherapy was limited by age and by comorbidities and by the performance status of the patient. Performance status meaning how fit that patient is. Now, since we are in India, a lot of our patients have not so good performance status at that particular age. For example, a 60-year-old Indian may not have the same fitness as a 60-year-old Westerner, for that matter, and an 80-year-old Westerner would be more fit or possibly would be more fit than a 60-year-old Indian. So, taking all these sort of drawbacks into consideration, once we have targeted treatments, primarily what benefit is there for the patient is that the side effects are limited or the side effects are minimized. What are the side effects? So, chemotherapy is, if you put it across to a lay person, chemotherapy is like, what should I say, carpet bombing, where you're not identifying friend from foe. You're giving cytotoxic chemotherapy in such a way so that all the cells in the body are dying, all the dividing cells. So the cancer cells are dying, your healthy cells are dying. So when certain healthy cells die, there are a lot of side effects like hair loss, like GI side effects, like gonadal toxicity, and whole lot of things like that. So when the side effects occur, many patients in India, they suffer from these side effects, and that leads to the treatment associated morbidity and mortality. So automatically what happens is somebody would either not be able to continue the treatment or would not be able to withstand the treatment, or we would have to reduce doses in order to minimize the side effects in order and in the and what happens is that the outcomes may not be as good as what would have happened with full dose chemotherapy. In this background, immunotherapies are like precision strikes or surgical strikes. So they will go in and target the tumor or the tumor cells, and so the side effects to the off-target toxicities are kind of limited to an extent. Now, this is the broad difference between cytotoxic chemotherapy and immunotherapy or targeted treatment. Now, when we come to targeted treatment, also there have been a lot of advancements. As Dr. Karthik pointed out, CAR T cell treatment is also a kind of targeted treatment, and it is tumor specific, where we are re-engineering our immune system or the patient's immune system to target and find out those tumor cells and kill them. So CAR T cells have also been advanced over the last, what should I say, a decade now. And in India also we have good CAR T cells available for the treatment of lymphoid leukemias. Unfortunately, for myeloid leukemias, at present, CAR T cells are still in the research mode. There are a lot of studies going on in China and in the Western countries on CAR-T cells in myeloid leukemias, but as of now, they are still not commercially available. Now, coming to the other immunotherapies, there are some very good drugs, off-the-shelf drugs available for lymphoid leukemias, like monoclonal antibodies and bispecific antibodies. Now, what are these bispecific antibodies? They basically, again, help to bring the body's immune system closer to the tumor cell, and that leads to cell death, the tumor cell death. So these molecules are now available in India. I mean, I would say bites can be made available in India. They still need to be imported, especially the bite for what should I say, lymphoid leukemia needs to be imported. But the monoclonal antibodies, which are targeted to the lymphoid leukemias, like case in point is inotuzumab, that is commercially available in India, and we have been using this molecule for many years now. So what happens is the outcomes are such that you can effectively treat older patients, patients who would maybe 20 years before this would be left with only palliative chemotherapy or best supportive care. Those patients now you can treat with curative intent chemotherapy. So that is a major advancement. Then you can basically treat patients who, let's say, progress on cytotoxic chemotherapy, or you can treat patients who have progressed on let's say first line chemotherapy. So for those patients also, these agents become important in order to achieve disease cure. Another place where these targeted treatments are used is prior to a stem cell transplant. Now, as Dr. Karthik had pointed out, the primary aim, and Dr. Subbaiah also had pointed out, the primary aim in a case of leukemia is to get the patient into a remission, which is basically called disease control. Now, once the patient is in remission, we need to consolidate that remission. And the best way to consolidate such a remission as of now is with an allogenic transplant or a bone marrow transplant, where we are putting in a new immune system which will take care of the leukemia cells, new immune system from the donor. Now, in many patients, once we have decided that yes, we will want to do a transplant, uh, the disease and we give chemotherapy. Many a times, after using whatever chemotherapy protocols that we have used, the patient does come into a remission, but the depth of remission is not very good. Basically, what it means is the patient has some amount of residual disease in the bone marrow. Now, immunotherapies in this regard, like inotuzumab or blinatumomab, which is the this thing with the bite, they can help you achieve MRD clearance, or basically take care of the residual disease that is there in the marrow. Now, once the residual disease is taken care of, the outcomes of the transplant are better. It is simple to understand. If there is some disease on board, the patient has higher chances of relapse. Whereas if you clean out the bone marrow nice and once and for all, and then you put in a new immune system, then the chances of relapse post transplant are much less. So the outcomes are better. So this is another sort of indication where we can use targeted treatments. So yeah, that is pretty much it. Now, if you there is also another area where we may have to sequence such treatments, like whether we should use CAR-T cell first, whether we should use inotuzumab, whether we are going to use blinatumomab, where we are going to sequence in transplant. So those are also issues which are kind of decided on a case by case basis depending on the patient in question. So that was, I think, a summary of how targeted treatments and precision medicine is helping leukemia treatment nowadays.
So, yeah, thank you so much for explaining. My next question is to you, Colonel Ajay, that how important are awareness, early detection, and patient education in improving leukemia outcomes?
Thank you, Dr. Vaishnavi. I'll say awareness, early detection, knowledge, all are very important. And this is the work which Indian Cancer Society is doing day after day. Now, regarding awareness, in leukemia, the symptoms appear very vague: fatigue, recurrence of fever, recurrence of infections, and things like that. So, if a person is aware, not only for leukemia but other cancers also, what are the signs and symptoms of cancer, especially leukemia in this case? So they will rather go to a doctor than to ignore. What we find in underprivileged community and even educated people, they ignore the symptoms. They say, "नहीं वो season is changing." Like in North India, से मौसम बदल रहा है. So they just ignore it, and then at a later stage, it becomes very difficult, and the prognosis is also poor. So next is it reduces stigma and stress and fear of the patient if you are aware of the signs, symptoms, and treatment options available. We in the Indian Cancer Society, we have IEC material, we have got a mobile app, and in the digital world, we have got platforms uh, on internet. In our e-learning courses we have on fundamentals of cancer. So it is just at the tip of your fingers. You can always become aware, and awareness will definitely reduce the stigma and the fear. Next is it encourages in the community to go and donate stem cell, big names now, and big treatments are there, targeted therapy where a lot of BMT, bone marrow transplant. So donors are required. So if somebody is aware that our donation will help our relatives or friends, so they will rather go and donate, and they won't be scared if something will happen to me. Now, early detection is early cure, like that's a dictum. So no need to elaborate on this. It improves the, like I said earlier, the treatment options available, and the treatment per se. It will improve the treatment once it is detected early, and it reduces the treatment burden also. Side effects would be less, other organs will be less affected, and that enhances the survival rate. So that is about early detection. Now coming to knowledge is power, as they say. And like Dr. Ghosh had very nicely explained, I, being a military man, I could relate very fast. Carpet bombing and precision bombing. Carpet bombing is when you treat a person with chemotherapy, you blast him with lot of bombs. Whereas targeted therapy, immunotherapy, you target a particular area which will have less effect. So if you have the knowledge, you were firstly aware, then you got detected with cancer. Now you have to become empowered. It will not only the doctors will help, the caregivers will help, the counselors will help in making you understand the knowledge, the what you're going to foresee or what is going to come. Like Dr. Ghosh, again I'll repeat, he had mentioned that many people leave. Yeah, it is now doomsday and we can't do anything about it. Let's leave the treatment. So unless you have the knowledge of what type of cancer you have and what are the protocols, so it becomes very difficult. So that is how knowledge about that particular cancer and the treatment protocols will help you. I think this is what I had to say about awareness, early detection, and knowledge. Thank you.
Thank you. So, taking this discussion forward, my next question is to you, Dr. Vinita, that what key improvements are needed in our healthcare system to ensure timely diagnosis and treatment for leukemia patients?
Yeah, thank you. And I have been hearing my panelists. It was great learning. And the best thing which I'm just listening that early diagnosis, that means that it is really needed that we have advanced diagnostic systems in our places. And the molecular and immunophenetic typing testings are important. We also need to have a multidisciplinary teams, which are very important. And while I was listening to my previous speaker, Dr. Colonel Sir, So I was thinking that that's very important, that there should be a very well communications between the healthcare providers and people like him who are working for it. Important is that the data which we were talking about, that we have such so many of patients, the data driven things are very important, because now the time when we talk about this data helps us a lot to get the insights about what exactly is needed in the healthcare systems. And if you see the drugs, availability of drugs, the good infrastructure, and leveraging the tools like artificial intelligence uh, are very crucial, but still we have to go a far bit about it. And when we say the diagnosis, the laboratory services performance need to be very good. And the laboratory services still, I feel, because when we say it's early diagnosis, it's important to have a very good laboratory services performance, which I mean, in some places it's very good, but mostly it is lacking, and because of lacking, this early diagnosis cannot happen. So, and the building of multidisciplinary team, because our doctors are here, they know much better. But it is important that we have a good team. The clinicians are there, the pathologists are there, the laboratory scientists are there. And this makes a lot of difference. The infrastructure is so good. We have very good rooms, the HEPA filter rooms and all. So all these things makes how this treatment can be enforced and this diagnosis can be strengthened. Now it's coming up to the strengthening of health policy. It's again a very important thing, that these policies need to be revised, and this I mean specific policies. I was just going because I have been dealing with the blood disorder of thalassemia, sickle, and hemophilia as well. So there was just a loud thinking that we need to have a center for blood disorders, where the leukemia and such disorders can be treated well. And maybe this will be helpful if we have one center, a good center of competence in each state. It will be very helpful to take it up. And this overcome of cultural barriers is very important, because again, this misconception, as Tanal sir has said, that about cancers, it has to, the stigma has to be reduced, because I was hearing it. That's very important, that these things has to be taken care while we talk about how the infrastructure and healthcare services can be improved in such a way. Thank you.
Yeah, thank you so much. So, my next question is to you, Dr. Subai, that how are newer targeted drugs improving patient care?
Yeah, so as we see the treatment of leukemia has improved, uh, so we now encounter even a lot of relapse patients. So they are a subset who are who, who could not sustain the remission for a long time, and then with advancing therapies we have options for them too now. But the problem is again the accessibility, availability are an issue in a country like ours, where many patients are not supported by insurance and even the drug costs are so high. So the some like what Dr. Karthik and Dr. Shouriyo discussed, we have got a lot of newer targeted therapies, precision medicine. One is blinatumomab, where it's a bite, or what we call as a bi-specific T cell engages. Naturally, we have immune system. It has natural anti-leukemia effect because the immune system is so good. It prevents any evasion and development of a malignant neoplasm. When our immune system fails, we encounter these kind of disorders. And one option is to strengthen the immune system by these by specific T cell engages. So what it does is it binds to the tumorous B cells as well as the host T cells, and it enhances the T cell mediated killing of the abnormal malignant B cell. So the response rates as high as 80% have been reported uh, when these relapse patients are managed. Amongst the relapse population, this drug can give a response varying depending upon how bad the disease is, how the burden is. Maybe reports are asked from 40 to 80%. But again, the cost and accessibility are an issue. The other agent is an antibody drug conjugate like inotuzumab, where and the abnormal malignant cells, they are killed by an antibody which is conjugated with a toxic agent like, for example, inotuzumab ozagamicin. The inotuzumab is an antibody which binds to those abnormal malignant cells, and ozagamicin is a it's a toxic agent which kills the cell by causing some the toxicity to the nuclear material. So those are the agents we have. So with the advancement in the precision medicine, we have got all these new agents which can target the tumor cells more in comparison to the normal cells. So that we can achieve good response and what has been discussed earlier, like an MRD negative status, so that we can take them for consolidative transplant. So these are available. A lot of drugs are in the pipeline too, and again, maybe in the upcoming years, we would have our manufacturing or the generic companies might bring these in common use in the country too.
So, yes. Uh, my next question is to you, Dr. Karthik, that in your experience, which patients benefit most from CAR-T therapy or targeted drugs, and why?
So basically, I think it was a very elaborate discussion. I just wanted to quote Dr. Colonel Ajai Tomar sir when he said, saying, see, we have to give a good communication to the patient, saying, see, it's still curable, saying leukemia is not the end of the world, saying, see, you have targeted therapies, you have treatments which are now still increasing those numbers to beyond 30-40%, which we were seeing. So like Dr. Subbaiah was saying, once it was relapsed around a decade ago, relapsed disease was considered as a dead end, saying, see, you didn't have much options except banging them with more chemotherapy and trying to bring them under remission. So that has changed now, saying that now you have some precision drugs which you can still give them some hope, saying, see, you have relapsed, where we know that the disease has come back, but you still have some hope to still have a curative option. Or else previously, those kind of patients were in a palliative group, where you would tell them, saying, see, we are going to give you best comfort care. But now at relapse, you're still seeing a curative intent therapy. So that is a very good advancement with science, and I think it's going to improve with time. One of the basic understandings which I'm just going to quote Dr. Shouriyo, so that we understand how these targeted therapies actually work, saying, see, previously when we were giving chemotherapy and carpet bombing, like we were saying, a lot of the outcomes depends on the tumor biology, saying, see, it depends on how bad the terrorist is that we put the bomb and kill him, saying, see, we have to bomb them and then wait and see whether they died or not, saying, if you had a TP53 mutated or a very severe genetically resistant cancer, that kind of a bombing might not work. The cancer would still be alive. Whereas when where the tumor biology made a very big difference. So with targeted therapy and CAR-T, the tumor biology actually makes no sense, saying, see, you, whatever be your biology, if you are expressing CD19 or CD22, we can still kill you, saying, see, the precision medicine makes that kind of a difference, where it's more of just tumor burden, saying, if you just have an MRD disease, I can still give you some CAR-T or precision disease to make you MRD negative. It's still going to give those outcomes. So those kind of differences make a very big difference, where the genetic kind of mutations which we were looking for to label them as resistant or high risk now kind of blurs, because we still have the weapons to get over that kind of a disease. So that is one kind of an advancement. Inotuzumab versus Blina. These are the two therapies we have. Both, I think Blin is still restricted to a very small subset because of the cost, because it's a 28-day infusion and the costs is for a very limited set of population. But Blin is more like a bridge to bring the patient into MRD negative state, since we know the outcomes are better once you reach that. So if they have access to it, Blin can do the job. But it falls short when we are talking about extramedullary cancer, like Dr. Subbaiah had said, in the skin, in the CNS, if there is cancer in your testis. These are all like sanctuary sites where the cancers can go and hide. So Blin kind of falls short in those kind of areas, but inotuzumab still has shown effect, saying it can go and search and kill even if it's hiding somewhere. So inotuzumab is very useful in these kind of relapses where you can still bring the patient into remission and you can do it. Precision medicines, we still talk about other drugs like TKIs, which is like pH positive. That's a particular subset of ALL where you can give you can test the mutation and find which drug it's sensitive to and give them. We have a big array of nilotinib, dasatinib, ponatinib. So these are the drugs which we can target and still bring that clone down. So that is very important in the ALL spectrum. Acute myeloid leukemia is a little difficult because our array of weapons are slightly less. We still resort to conventional chemotherapy, but still the targeted therapies in AML is evolving, saying, see, we have FLT3 inhibitors, which was a clone which always used to hide, saying we were always confident saying the cancer is gone, but that clone comes up after some time. So we have targeted agents even in the myeloid era, where we have FLT3 agents, and newer drugs like gilteritinib, though they are restricted by cost, kind of change the treatment outcomes of the patient, where we can change it into a tablet kind of a regimen and patient still does well. So targeted therapies are making a big difference, considering that once we have access to all these drugs, there is no leukemia which can actually get we can say is very bad. Coming to CAR-T cell therapy, who benefits is in a set of patients who are very old, who are transplant ineligible. We used to tell them, saying, see, no, we can't give you a curative intent therapy, but these can still be CAR-T eligible, considering that CAR-T just requires a minimal kind of a cytoreductive chemotherapy, which most patients can tolerate. Even if you are a 78-year-old, that kind of a fludarabine-based therapy should not cause so much harm. And the side effect profile post-CAR-T is more similar to how you would have a dengue fever or a CRS, like a cytokine release kind of a picture, which is still manageable with the current set of medicines which we have, like tocilizumab. All of these we can still use to get over those side effects. They are fairly manageable, and the levels of CRS which we see in our current Indian setting is kind of much more in control than what we get in the research kind of a settings in the Western data. So I think it's a manageable subset of population who are actually being palliated, are still seeing some hope in the form of curative therapy if we can select and give CAR-T for some people. So do all patients post CAR-T need transplant? I think if we are in a setup where we can discuss with the patient and still give them that benefit of cure post CAR-T, and if it's an elderly patient, we can monitor the side effects and see if they are for example, so once you give CAR-T, you can monitor their B cells, saying, see, once the cancer is gone, the B cells are also going to be low. So we monitor their B cell aplasia to see how much the CAR-T is still persisting in the body. So if it's still persisting, then we can get away with just CAR-T cell therapy. So this kind of summarizes, saying targeted therapy and CAR-T cell has changed, has broadened the brackets to involve more patients who can still be under the curative intent therapy, and that is how we have changed, and it's evolving. So I think we are going to have more patients. The main clause is going to be the access and the costs, which are going to be prohibitive. I think once the patents go off, those will be reachable to all the public also, similar to how we had rituximab, which was restricted. Now everybody is able to access it. I think we are reaching there someday.
Correct. So my next question is to you, Dr. Shouriyo, that what impact are recent advancement in therapies and treatment approach having on patient outcomes in leukemia care?
Yeah, so in short, I mean, we've had an excellent uh, panel discussion so far, and all the esteemed panelists have pretty much explained in great detail the benefits of what we are doing right now. I will keep it short. The impact in terms of patient outcomes are two. One is better survival and better disease outcome, but there's another impact also, increased financial burden and financial toxicity. Now this has an implication. So if you look at traditional insurance policies, many of these policies don't cover these targeted treatments and immunotherapies. So this becomes a sort of thinking point for the lawmakers of our country and for the insurance ombudsman to understand that in this age the these kind of treatments, although expensive, are life saving. So in this situation, this becomes an important point to consider, that immunotherapies, yes, definitely over a period of time the patents will go, there will be reduction in the costs, and for that matter, CAR-T cell in India is one, what should I say, I think 1/50th the cost of a CAR-T cell in USA, right? So a CAR-T cell in USA costs close to $1 million. Here it is close to 25 lakhs. So there's a huge difference in the cost of treatment, and that is possible. That has become possible because of homegrown development of CAR-T cells. Now, all said and done, even then, somebody affording 25 lakhs, 30 lakhs, 35 lakhs is difficult for in an LMIC like India. So here it becomes important to expand the scope of equitable healthcare through maybe government schemes, maybe increasing the limit of care in the various government schemes, maybe creating more awareness for the insurance companies to take these kind of treatments into their scope of insurance, and also uh, telling patients that yes, these are the treatments which should become more. I mean, cost should not be a concern if we can support such treatments and if we can support such patients. So these are the two things to think about. One is improved outcomes at the cost of this financial toxicity, which we still need to address in this country.
Correct, and I believe that is something that it gets highlighted session by session. So that is something that needs to be addressed. So my next question is to you, Colonel Ajay, that how can patient support initiatives and advocacy program help bridge these gaps that we are discussing in terms of accessibility and affordability for advanced leukemia treatments? Can you hear us?
Sir, you're muted. Could you please unmute yourself?
Thank you. Sorry. So I'll be covering all type of cancers. What we find, like in AIMS Delhi, our Delhi office is just co-located there only next to the gate number 6. So what happens? People, they come there. They have come from their villages. They come from tier 2, tier 3 cities for treatment, but they don't know what to do. So it is very vague as to what is patient support. Patient support is guiding a person through or navigating through a hospital. Where is the OPD? Where do you get the OPD card made? What are the Ayushman Bharat? How do you find whether you are enlisted in that scheme, Ayushman Bharat? And Delhi Arogya Kosh, similarly in Bombay, we guide the patient. That is one small step which we do. Our counselors, our volunteers go there, and this is how we support these patients as OPD patients. Now coming further, those who have, since we are topic is after treatment also, so we have got rehabilitation centers in Delhi, in Bombay, where people they are given vocational training, and for other cancers, breast cancer, once the mastectomy is done, so the swelling all over, so they have got this lymphedema sleeves which they wear, and then this chai pe charcha, that is they discuss their problems mutually among the patient support group. So we have a patient support group also functioning. So these are the things how we help these people. We raise funds for them. Some underprivileged people, if we have the amount from the CSR funding, we help them. Otherwise, we guide them to the various government schemes for funding. So this is the patient initiative at our level, at lower level. Now coming to advocacy, you asked for advocacy. Okay, advocacy, we are invited as Indian Cancer Society, being one of the oldest health NGOs of India. We are invited to the Parliament of India for giving our views on how to make cancer drugs cheaper, and how to make cancer a notifiable disease. It's a big debate going on. So we give our inputs. We gave our inputs for to a petitions committee group headed by Dr. Gupta. So they have recommended to the Ministry of Health and Ministry of Health and Family Welfare to notify cancer as a notifiable disease. So this is a big step. So these are how advocacy helps in, like Dr. Vinita also said that we must have some centers, leukemia centers or some blood, some centers in each state. So these are the advocacy which we propose, and hopefully government will take note of it and implement such policy changes. Thank you.
Yes. So thank you so much. My next question is to you, Dr. Vinita, that what kind of training or capacity building initiatives are needed for doctors, nurses, and caregivers involved in leukemia care?
Sorry, I couldn't hear the question, please.
Yeah, the question is that what kind of training or capacity building initiatives are needed for doctors, nurses, and caregivers involved in leukemia care?
So, very well said. Very important that we have
We can hear you, ma'am. Are we audible? Uh, Dr. Vinita, are we audible to you? Because you aren't audible to us. I think there is some network issue at her end. So, since we are heading towards the conclusion of the session, I will just quickly take your opinions on some of the questions that are a way forward on how policy collaboration and global call to action through this initiative that we are doing. So, my first question is to you, Dr. Subai, that what are the common side effects or advanced treatment that you see in your experience, and how do you manage them?
Uh, uh, we give a lot of chemotherapy, and the world knows well with chemotherapy, with the toxicity of the drugs itself, the main problem what we face with during the cytopenic phase when the counts drop down, the fatigue, the infections, bleeding, they require intense supportive care in the form of broad spectrum IV antibiotics, with blood complement supports, and when they become really sick they might need critical care support. So that would be the most important thing whenever we give intense toxic therapies like this. And we have learned over the years that with advancements in precision medicine, with availability of monoclonal antibodies, we also see some new forms of all these complications in the form of these cytokine release syndromes and the ICANS or immune effect associated neurotoxicity. So we should be prepared to manage these things when we see advancement in the medical, the medicaments also. So supportive care would be the foremost thing, and we should understand the toxicity. The best possible, we can give prophylactic treatment or try to prevent the best possible. If not, when we encounter these prepared they might cause cytopenia. So, managing the cytopenia with antibiotics in the form of factors or the liver toxicity with supportive care, avoiding hepatotoxic or nephrotoxic drugs to prevent further damage to the other organs. And when we encounter these cytokine release syndromes or ICANS release syndromes, we give more immunosuppression. Sometimes in CAR therapy, to just destroy the card when it's refractory to the steroids or the immunosuppressants what we give. some like you need further give some chemotherapy to take away the effect of CAR-T. So we need to understand the newer drugs, expect the complications, and then try to prevent them wherever feasible. If not, we need to manage them uh, with available supportive care, whatever is available now.
So yes, my next question is to you, Dr. Karthik, that how do you handle complex cases or patients with limited treatment options?
Yeah, so before I go to that question, I'll just brief on the previous question you had asked Dr. Vinita on capacity building. And so I'll just take that answer saying, see, right now, I think India is a very heterogeneous population with multiple players giving different chemotherapy. So I think HCC is one of the organizations which is headed by both the TMH team under Dr. Manju Sengar and CMC Vaishnavi leading that. So that is like and data from Delhi. So they're kind of doing a elaborate job and integrating all the data, and they do have sessions for training the nurses and independent sessions on transplant. So we are building kind of a like an Indian data setup, and it's and the evidences are coming out saying we do not have to look up to the West for our data. So I think that is a good job that the HCC is doing in training the staff and to get the hands-on and capacity building. So I think that is summarizes what was your question. So coming to what we'll do in complicated cases, so that's one of the most common situations we face in India, because most of them are either old and or arrive late with an infection. So in ALLs and AMLs, usually what happens is if the patient has a blaring infection or sepsis, or his patient is in the ICU when you make the diagnosis, that kinds of ties the hands of all the hematologists, because you whatever therapy you give is going to be immunosuppressive. So that takes away the chance that the patient can overcome that infection. So when a patient is really sick and when the patient is diagnosed as leukemia, so that point of time, I think we resort more to kind of truthful and valid discussions with the family on what are the outcomes we are facing, because that does not there is no point in talking about the outcomes of the cancer alone, because now the other problems also come into picture. So if a patient who is having a multi-organ dysfunction with sepsis, even if he doesn't have cancer, the numbers fall to less than 10%, 10 to 20%. So when those kind of compounding problems come together, so the discussion should be very realistic, saying how are we going to reduce the tumor burden and kind of give him the time to recover from that kind of a situation. And then later we can probably, if he is out of that, we can probably consider curative intent therapy if he recovers from that kind of an acute situation. Other difficult situations where we commonly face is finances, where like Colonel Ajai Tomar sir said, so mostly we look up to some form of funding so that we can get this treatment across to people who can't afford. So there are multiple centers where they do offer trials and where the patient can actually access therapy which is currently curative intent. So we would probably refer them to those kind of settings in the government settings where the treatment is still available. So that's more of a stigma or the fear of going into a bigger system which restricts the patient and wants them to take treatment. But mostly we see that there are lots of patients who migrate just for the treatment. So most of the bigger centers like Delhi, AIMS and TMH Mumbai and CMC, we see people moving across states purely for the cure, and it makes sense because it's a very short form of treatment and they can go back home with the cure. So those kind of places where we can get the care across makes a big difference for people who can't afford therapy. So treatment is still available. It's just a matter of how we can give it to the patient. So if we can't cure it, we should guide them and show them the right way of where it's available.
Yes. So thank you for explaining. My next question is to you, Dr. Shouriyo, that how can hospitals and specialities work together to improve care for leukemia patients?
Yes, so I would like to say that cancer treatment in general is a multidisciplinary teamwork where we have, you know, the clinical hematologist or the oncologist. We have, what should I say? allied specialties involved. So it depends from cancer to cancer, especially for leukemias. Let's say there is a pediatric group, there are children with leukemia. So you need to have educators, you need to have counselors, you need to have psycho-oncologists, you need to have whole lot of allied health specialties involved in the treatment of that patient. Same goes for adults. So nutrition, clinical nutrition becomes a nutritionist, not a dietitian, but a clinical nutritionist becomes very important in the patient's care. Nursing becomes important, physiotherapy becomes important. All the allied branches and the other clinical specialties become important in the treatment of a patient with cancer. Now, as Dr. Vinita has pointed out, capacity building is also very important. So, unification of care, or having apex institutes in each state, which are kind of following, and we should all follow the hub and spoke model. So, there should be a proper referral system in place. There should not be repetition of tests. So, if the tests are done at a central reference laboratory, what happens is many patients do a lot of doctor shopping, or they go from one state to the other for the same. They're scared, they are kind of anxious, they want a second opinion, or they want another answer. They go from state to state in search of better treatment, but end up spending more because they're having to repeat a lot of investigations which may have been done in the previous center. So we see this umpteen number of times. Now, these things end up basically, these things lead to two problems. One is waste of time, and these are critical illnesses where you need to, act quickly. The second thing is waste of logistics in general, like um, finances, time, all the logistics support that has gone into the patient, all that is basically waste of resources. So unifying this, like Dr. Karthik pointed out, the HCC, that's a very, should I say, a very crucial, role is being played by the Hematology Care Consortium. There are disease-specific groups. So you have a leukemia group, you have a lymphoma group, you have a myeloma group, you have other cancer-specific groups where they are unifying care. The protocols are kind of streamlined. That there's a scope for streamlining of protocols. There's a scope of better data collection and better reporting and better outcome analysis. So that, and there is also a stigma in this country about clinical trials. So when patients come to us and we offer them, maybe there is a trial for first line treatment, and we offer them that, and they are initially, and they're scared that I don't want to be experimented upon. But here it is important to note that for cancer, as on date, the best treatment is in form of a clinical trial. It may be a standard treatment approach in a trial format, in a prospective trial, or maybe a new experiment, new combination treatment, or whatever. But clinical trials do form a major, whatever we are discussing today is data from trials. So that stigma has to be also taken care of. So patient advocacy groups who are counseling patients need to also appraise them of this thing. Coming from a patient advocacy group or coming from a patient support group, that will have more impact than me saying to the patient, than me telling the patient that yes, a trial is good for you. So capacity building, having unification of care, having a hub and spoke model like is there in the West, having a better referral system, having a better, what should I say, so for leukemias and for hematologic malignancies particularly, we are heavily reliant on specialized molecular tests. So molecular tests, cytogenetics, these things are first of all not available in every center, and even if they are, if the person analyzing those tests are not of having proper expertise, then there are chances of errors. So if we can kind of iron out these areas, then I think leukemia care will improve over the years in this country.
So, yes, thank you so much for summarizing it so well. My next question is to you, Colonel Ajay, that how can collaboration between healthcare providers, policymakers, and civil society help strengthen the long-term care and survivorship of leukemia patients?
I'll be very short because we are running out of time. The doctors and the healthcare providers, they provide the clinical expertise and the follow protocols. The government of India, like an NHA, they will provide survivorship and they'll make policies. And we as civil society, we will integrate the policies and help at the ground level. And once everybody gets integrated, the results would be better. For example, we collaborated with TISS, Tata Institute of Social Sciences, to implement a program on in Maharashtra for Pradhan Mantri Arogya Mitras. We had created training modules and we gave them 28 hours of lessons. So that is how we can move forward together. Thank you.
Thank you. Dr. Vinita, are you there on the call?
Yeah, yeah, please.
Yeah. So, ma'am, if you would like to summarize this session and give and help us understand that how can collaboration between government and private sector and NGOs help strengthen leukemia treatment and support systems?
So, what you are doing today at VOH, it is important that the collaboration among the government, private sector, NGO can play a very significant role in leukemia treatment and pooling resources and better outcomes as well. But the concern is ki the problem which we are facing is for infrastructure, which is very important. And as the concern has said, yet we need to have a very good awareness and early detection, which is very important. And this can be only done by the NGOs only, because they can only strengthen the system. And for the strengthening of any system, it's important that everybody plays a very important and crucial role. Like our experts, they have been talking about how the treatment can be done. Similarly, if the government is able to do anything, I mean, about the treatment, it provides funding, policy frameworks. The private sector contributes basically about the technology, infrastructure, and financial investment, how it has to be done. And NGO are very important. They play a community support like emotional counseling. What Dr. Nair was saying, that patient navigation, affordable services from one place to another, they have to move. He was telling about the games example. So all have to come together, because while we draft the policies for any policy, all the clinicians are needed, because they are aware and they know the basically what treatments are required and how rapid the treatments are being changed. So there is a very good need of policy revisions and all for every time, every 1 year or 2 year, there should be a revision of policies. And important it is everybody has to come forward, because alone government cannot work. It's like a entire when we talk about the government policies, it's like you have to sit on the both of side of the tables to prepare the policy. You have to listen the patients also, you'll have to listen the clinicians also, and then the policy can be prepared in a manner where it is well tested, I should say, like that. So I mean, today the sessions which has been held for the leukemia treatment, but it is meant that all have to come together to give a very contributory efforts to treat leukemia and other diseases as well. And we at the government try to communicate with everybody. I mean, we regularly have seminars, workshops, and all. But yes, still there is a lot to be done. Thank you so much.
So, thank you so much to all our panelists for taking out time and joining this session and making it such an insightful session that starting from understanding the treatment and then outlining the gap and how can we address all this. We have covered it all, and thank you so much to each one of you for taking out time. And we look forward to have more such initiatives so that we do our part in the best part. Yes.
Thank you so
So,
much. It was a good insight to me from all clinicians, and I'm very thankful to everybody because this was a very good learning, and we understand in a different way also.
So thank you so much, everybody. I mean, I'm very honored that I was a part of this panel, and it was a great learning. Thank you so much.
Thank you. Thank you.
Thank you so much. Thank you. Bye bye.